Welcome all of you to this live program, The Orthopedic Principles. Today, our guest of honor is Dr. Mette Andersen from Tromso, Norway. Dr. Andersen obtained her medical degree at the University of Tromso in 2001, and then did her ortho specialization at the Oslo University Hospital and Bærum Hospital in 2013. And the same year, she was also certified by the Norwegian Association of Sports Medicine as qualified sports medicine physician. Dr. Andersen finished her PhD on the treatment of syndesmotic injuries in 2018. Currently, Dr. Andersen works at the LRS Hospital, which is a private hospital, and focuses on arthroscopy surgeries of the knee, ankle, and foot. Dr. Andersen has been the president of the Norwegian Arthroscopy Association from 2019 until Feb 2023. She's an ESSKA FR's board member and the chair of the ankle ligament pathology certification module that ESSKA has recently launched. So today is my great honor to introduce you to Dr. Mette Andersen from Tromso, Norway. Over to you, Mette.
Thank you. Thank you for the invitation to do this talk and present some of my results from earlier studies. So the topic today are high ankle sprain in athletes, evaluation and treatment. And I will just like this. It's always good to start up with a case, I think. This is a patient of mine, high national and international level junior kickboxing, injures her right ankle, and we recognize the injury mechanism as hyperdorsiflexion and external rotation together with axial loading. So she presented with a positive squeeze test, deltoid tenderness along the interosseous membrane, but there was nothing to see on plain X-rays. At coronal MRI, we can recognize edema spreading up the interosseous membrane and also in the lateral malleolus. But at the medial side, there is not much to see. At the axial scans, we can see the fluid spreading along the tibial bone above the interosseous ligament. We cannot visualize the anterior tibiofibular ligament in the coronal plane, and in the axial plane, we better see the ITFL injury. At the back, we can follow the continuance of some of the PITFL fibers, and in the sagittal plane, a fair amount of edema in the posterior malleolus, but nothing too much. So to sum up our findings after clinical and radiological exam, there is an injury of the AITFL, seems to affect the interosseous membrane. Also, the superior fascicle of the anterior tibiofibular ligament was injured. There was no obvious PITFL injury and no injury of the deltoid ligament, and no obvious increased tibiofibular distance. And this reflects our challenge when we do our evaluation of these patients. The first challenge is always not to overlook them, but when obvious, the question is which injury are stable and which is not. And this brings us to the classification of these injuries. A much used classification system is the West Point ankle grading system presented by Gerber and later proposed modified by Calder, where grade 1 injuries involve a partial tear to the anterior inferior tibiofibular ligament, a stable injury. Grade 3 injuries involve complete disruption of the syndesmosis ligaments, and there is a frank diastasis at X-rays and a clear unstable injury. Grade 2 are the challenging ones with a complete rupture of the AITFL and a partial tear of the interosseous ligament, but no sign of diastasis at X-rays. Even though there might be a subtle instability, which is important to diagnose as it will impact the choice of treatment. We can look at our diagnostic challenge like a puzzle, as still there is not one uninvasive test that will give us the answer about stability. Injury mechanism together with findings at MRI and or ultrasound and clinical testing, though, might help. Why is it important to treat the potential instability? Because misdiagnosed, it might lead to delayed return to sports, anterolateral soft tissue impingement due to inflammation of the anterior tibiofibular ligament or chronic instability might evolve, and the relation between overlooked ligamentous injury and ankle OA are proposed, but is not very well stated. In this study, Valdebarano found that among patients with ankle osteoarthritis, almost 80% with post-traumatic and 60% after ligamentous injuries. An ankle OA can be devastating for a patient. The mental and physical disability associated with end-stage ankle osteoarthritis is at least as severe as in end-stage hip arthrosis. So syndesmotic injury are more common than lateral ankle sprain in collision sports and in sports that involve a rigid immobilization of the ankle in a boot, such as skiing and hockey. About 20% of the athletes referred for MRI after an ankle sprain have a syndesmotic injury, regardless of lateral ligament injury. 13 to 18% of injuries in elite football are reported to be high ankle sprains, and the risk of injury is reported to be 14 times higher during a match compared to during training. The most common mechanism of acute syndesmotic injury is external rotation of the foot and a rapid pivoting ankle dorsiflexion in the pronating ankle. In this abstract presented at the ESSKA Congress last year, the authors found that injury history and an aversion mechanism increases the likelihood of syndesmotic injury. And according to a theory proposed by Peter de Hooch that he proposed during an excellent talk at the ESSKA Congress last year, forefoot can actually be the key when it comes to distinguishing grade 2A injuries from 2B injuries. A fixed forefoot seemed to cause a higher grade of injury. And this is important since it is reported that as much as 78% of athletes with syndesmotic injury presents as a grade 2. To the left in the Maguire injury, you can see that his forefoot is sort of for 45 days with this injury that was treated conservatively. To the right, and I apologize for the bad quality of this video, but here you can see arthroscopy and treated surgically. He returned to play after 63 days. Other injury mechanisms are described, and a combination with lateral ligament injury surely exists. Luis Enrique found that high-grade injury to the syndesmosis was typically associated with minimal traumatized lateral ankle ligaments and vice versa. And this corresponds with results from a study by Calder, where patients with concomitant injury to the ATFL were more likely to have stable syndesmosis. So how about the diagnosis? There are numerous tests that exist for evaluating the syndesmotic injuries, but no test alone will help us in differentiating the stable and unstable injuries. The reported reliability of each of these tests varies in the literature. In the previous mentioned study by Baltus and co-workers, they found that overall, a clinical suspicion of a syndesmotic injury has a sensitivity of 73% and a negative predictive value of 89%, and that a squeeze test was the test that showed the most discriminative value in acute injury, with a positive likelihood ratio of 2.2. Calder described high sensitivity of both the squeeze test and the external rotation test to predict instability, but the squeeze test was more specific than the external rotation test. The cotton test and the fibular translation test have reported poor reliability. Several studies show that tenderness on palpation over ligaments have high association with syndesmotic injury. Nussbaum also found a correlation between how high the tenderness spread along the interosseous membrane and rehabilitation time. The same goes for a positive squeeze test and external rotation tests that were associated with longer rehab time. He proposed that positive tests may be used to predict the severity of the syndesmotic injury. Calder found actually somewhat same results in a study where MRI was included. There was a high association between tenderness on palpation of ligaments and injury diagnosed with MRI. A combination of injury of the AITFL and deltoid ligament with clinical testing or verified at MRI were associated with an unstable injury. Both a positive external rotation test and a positive squeeze test were associated with increased severity of injury, and this algorithm was proposed to discriminate the unstable from the stable injuries. How about the radiological availabilities when diagnosing syndesmosis injuries? These include X-rays, CT, ultrasound, and MRI. We use X-rays to diagnose potential fracture, and the obvious diastasis in the grade 3 injuries will be visible, but we don't see the subtle instability at plain X-rays. Even with a concomitant ankle fracture present, there is increasing evidence suggesting that the traditional radiographic measurements used to evaluate the syndesmosis are inaccurate. Stress testing can be performed with the help of a fluoroscope, but have demonstrated low sensibility to detect instability. CT has proven to be a more sensitive method compared to X-rays, but requires bilateral scans to compare sites. But even CT scans can overlook the subtle instabilities, as these examinations are static and usually without weight bearing. Recent studies show promising reports of the use of weight-bearing CT to detect also the subtle instabilities, but still more research are needed, and the availability of weight-bearing CT is still poor. Ultrasound is fast and inexpensive and could be a valuable tool for diagnosis. It can be a dynamic examination because you can do it under weight bearing and during testing, but the examination is operator dependent. MRI is considered the optimal static modality for determining syndesmosis integrity, sensitivity and specificity of 95 to 100% for diagnosing AITFL and PITFL injuries have been presented, and that is as good as it gets. But without weight-bearing examination, you don't see the instability. So how do we interpret the MRIs? The anterior inferior tibiofibular ligament is visible both in the coronal and axial plane. In coronal plane, you can see the fan-shaped form from the distal lateral tibia towards the fibula. In high-quality MRIs, you can see the streaks, and in 80% of patients, you can differentiate the basset ligament, which is the lower part of the AITFL. The AITFL is also visible in the axial plane, but it's even better to follow its integrity in the oblique view, which is explained by the oblique fashion of this ligament. Here you can compare the axial and the oblique view in the same patients, and we see that the oblique view proves its integrity better. In the central part of the syndesmosis, we find the interosseous ligament. The ligament is visible both in coronal and axial plane. It's situated right above the tibiofibular recess, and it continues superior as the interosseous membrane. The posterior inferior tibiofibular ligament is visible in the axial plane, but better in the oblique plane. In the coronal and sagittal view, the intermalleolar ligament can be visualized in about 80% of the patients, situated inferior to the PITFL. So what do we look for in an injured ankle? Here you can compare normal oblique MRI of an intact anterior tibiofibular ligament and a torn ligament in an acute injury in the upper left picture. In the coronal, you can see the lack of a ligament and edema. This shows injury to the central ligaments, and we can again compare with normal findings. The yellow markers show the interosseous ligament injury and edema in the interosseous membrane, and the green arrow shows edema in the tibiofibular recess. Here you can compare findings of a ruptured PITFL in the oblique view in the upper left picture with an intact ligament in the lower picture. In the coronal plane, you can see edema, but the fibers actually seems intact. Injuries to the PITFL is not always visible on MRI. In a study by Rundell, they found that in patients with diagnosed PITFL injuries at arthroscopy, the injury could not be detected at MRI in 20% of the patients. Only the posterior malleolar bone marrow edema indicated the injury, and this therefore can be called as an indirect sign of syndesmotic injury. Periosteal stripping of the PITFL from the tibia is another indirect sign. You can see the blue arrow showing a layer of fluid between the ligament and the bone. This is from a paper by James Calder, and he called this the broken ring of fire. The presence of a subcircumferential periosteal edema around the tibia 4 to 6 centimeters above the ankle joint propose an interosseous ligament rupture and the fluid spreading, extruding along the interosseous membrane proximal to the joint. It is highly suggestive of a syndesmotic injury with an interosseous ligament tear. So the MRI is helpful for the diagnostics of high ankle sprain. But another reason for doing the MRIs is to diagnose potential associated injuries. Rellensman found intra-articular pathologies in up to 50% of the patients with acute, isolated, and stable syndesmotic injury. And MRI seems to be less accurate with time though. In the Rundell study, 27 patients with syndesmotic injury underwent an arthroscopy, and they found that MRI had been able to detect syndesmosis abnormality in all the patients, but MRI was less accurate with time, and because of this, the authors suggest MRI taken early, within 12 weeks. So back to our diagnostic puzzle. The only examination that alone can differentiate between a stable and an unstable injury is arthroscopy. But this is an invasive procedure which is limiting. So who should we scope? Which pieces in our puzzle points towards instability? About injury mechanism of dorsiflexion, external rotation with forefoot fixed. This is suggestive of an unstable injury, and the same goes for a positive squeeze test, an external rotation test, and deltoid ligament injury and or direct or indirect sign of a PITFL injury at MRI, and or diagnosed injury on ultrasound. And the finished puzzle also corresponds somewhat with the algorithm presented by Calder, as we've seen earlier, where positive squeeze test, deltoid injury, and or PITFL injury are findings suggestive of an arthroscopy assessment of the syndesmosis. Unstable injuries should be stabilized, but what about the stable ones? There are actually little evidence for the conservative management of syndesmotic injury. The ESSKA office have published a consensus for the management of syndesmotic injuries, and they propose this recommendation for the conservative treatment. 3 weeks non-weight bearing, followed by 3 weeks in a walker boot. Then return to normal activities as tolerated. This might seem a bit aggressive for the simple grade 1 sprain though, and this rehab program was presented in the Aspetar Sports Medicine Journal for the grade 1 injuries, who they propose will be back to regular training in about 3 weeks. They suggest to start with a period of initial offloading for about a week before gradual reloading and proprioceptive training during week 2 and 3. So what about the surgical treatment? The ESSKA consensus recommended repair of the syndesmosis ligament and, if needed, also the deltoid ligament before fixation with either a 3.5 millimeter tree or quadricortical screw, depending on the patient's MRI. This consensus is from 2016, and it only briefly mentions the use of arthroscopy as a diagnostic tool. And arthroscopy nowadays is regarded the gold standard. But how do we evaluate the syndesmosis during arthroscopy? In the literature, a syndesmosis widening of more than 2 to 3 millimeter or a positive drive-through sign are signs of an unstable syndesmosis requiring stabilization. And in the video, you can see the 3.5 millimeter shaver enters the tibiofibular space as a sign of instability. In addition to confirmation of the diagnosis by evaluation of the ligaments, arthroscopy gives the possibility to evaluate and treat concomitant intra-articular injuries like loose bodies and cartilage lesions. In the Relensman study, they found loose bodies in 11% of the patients with isolated syndesmotic injuries and cartilage injuries in 48% of the patients. In total, 90% of the patients had intra-articular pathology other than syndesmotic instability that required some kind of treatment. So what about this debate? Suture button vs syndesmotic screw. And does it even matter? In this RCT from 2018, we compared one quadricortical screw with one suture button in patients with Weber C fractures, and we found better clinical outcome scores and better radiographic results with less malreduction in the suture button group after 2 years. After 5 years, there still were better outcome scores and less malreduction in the suture button group. Also, there was a lower sign of ankle OA. Then we repeated the study, but now comparing suture button with one tricortical screw. Still Weber C fracture patients, and in this study, there were no significant differences in outcome scores or syndesmotic reduction between the two groups after 2 years. During the last years, several meta-analyses are published comparing suture button and syndesmotic screws. Most of them have concluded on better clinical outcome and less complication in patients treated with suture button. Still, the debate will go on, but we all agree on that reduction is important, is the clue. And we should choose the method that in our hands give the best reduction and is able to maintain the reduction until the syndesmosis is healed. In this study, we did ROC analysis, which proved significant association between the syndesmotic reduction evaluated at CT and clinical outcome scores. Better reduction, better functional outcome. This video showed the suture button technique, which is a simple procedure, skin incision before reduction and temporary stabilization with a pin. All 4 cortices are passed with the syndesmosis drill bit, and the needle attached to the suture button device is introduced through the drill hole and passed through and out on the medial side. The thread is pulled, leading the oblong button to the medial side where it's flipped. The threads are tightened and cut before skin closure. Why the proposed better reduction when using a suture button? This is the self-centering theory, which describes how the fibula finds its own way in the tibial incisure while the threads are toggled. So the dynamic property makes it more forgiving. There is increasing amount of studies published on direct repair of the syndesmosis with or without augmentation. The Stedman group did a cadaver study where IATFL repair and augmentation best restored the rotational kinematics and stability of the fibula and ankle joint in an isolated syndesmotic injury model. They therefore proposed this as an alternative or an addition to the suture button in the treatment of isolated syndesmotic injuries. These are the complications reported after conservative and operative treatment of syndesmotic injury. Stiffness is common. For the surgically treated patients, the complication rate varies somewhat according to fixation method chosen. Malreduction rates are high though, and reported as high as 40% in some studies. There has been a paradigm shift in fixation construct the last years, and this has been paralleled by a trend towards an accelerated return to sport protocol. There is currently no consensus for the post-op rehab or return to play protocol, but this is somewhat what is described in the studies mentioned. A walker boot for 4 weeks, fully weight-bearing in boot after 2 weeks if tolerated and pain-free, range of motion exercises allowed from about day 10 and proprioceptive exercises from week 3. Impact activities allowed from week 5. The Hood and co-workers have made this illustration where the rehabilitation is organized in 4 phases, and this describes both loading and range of motion progression through each phase. Progression from one phase to next one is based on described meeting criteria, and pain and swelling are used as guide for when one can progress to the next phase. What about return to play? What can the players expect? In the Calder study, they found the mean time to return to sports to be 44 days in the non-surgically treated group versus 65 days in the surgically treated group. While more specific for the surgically treated football players, the Hooch and co-workers found the average mean time required to start with on-field rehabilitation to be 37 days, team training 72 days, and official match play 103 days. Negative predictors associated with longer time to return to sports were grade 3 injuries, age above 25 years, and cartilage injuries. So what can we bring back home from this talk? Evidence pointing toward an unstable syndesmotic injury are dorsiflexion external rotation injury with a fixed forefoot, positive squeeze and/or external rotation test, and sign of ligamentum deltoid injury and/or sign of PI-TFL injury at MRI. We can assess the stability with an arthroscopy, and unstable injuries should be treated with transsyndesmotic stabilization with or without AI-TFL repair or augmentation and/or deltoid ligament repair. Patients with stable grade 2 injuries treated conservatively can expect to return back to sport in about 6 weeks after injury, while surgically treated injuries require about 9 weeks of rehab before able to return to play. Finally, I would like to mention the ESSKA certification program and ankle ligament pathology. This program is open to any specialist and not just for ESSKA members. The module consists of 3 parts: preparatory work with an exam, surgical skill assessment, and application to practice. Successful completion of the module will lead to the award of an ESSKA certificate of excellence in ankle ligament pathology. The deadline of application is on the 31st of May, and you can find the info on the ESSKA website. Thank you.
Thank you, Mette. Mette, you can stop sharing your screen.
I will.
Thank you, Mette, for this spectacular presentation, and congratulations for all the excellent work on syndesmotic injuries.
Thank you.
Mette, let's have a short Q&A. Mette, you mentioned a lot of tests like the squeeze test, the external rotation test, the Cotton's test, the fibula translation test. And there are publications that have looked at the inter-observer reliability as well. Useful in your clinical practice.
Can you repeat? I didn't hear you. Can you repeat?
Yeah, you mentioned a lot of these tests, right? Squeeze test, the external rotation test, the cotton test, the fibula translation test. Which one of these do you prefer in your clinical practice? Because there is a lot of inter-observer reliability, right?
Yeah,
Among
it is. It is.
the publications.
Yes, there is. It varies a lot. So I do a bit different in the acute injuries compared to the chronic injuries. So for the acute injuries, I seldom see them right after the injury. So to me, they come after a few weeks, and then I can actually do some testing. And I find this squeeze test, the test I rely most on, together with palpation of ligaments. So palpation tenderness up the leg, above more than 6 centimeters above ankle joint, together with a positive squeeze test. This is the signs I mostly rely on, together with MRI. For the more chronic injuries, I also use the tape test or stabilization test, where you put circular sports tape around the syndesmosis area, and you test the patients. They are standing, they do some exercises on the floor, and they tell you if it's less symptoms with tape compared to without tape. And this I found really helpful in the chronic cases.
Thank you, Mette, for that. And Mette, very commonly, we also encounter the deltoid ligament when you have an ankle sprain, right? So is the deltoid ligament injury also a part of a high ankle sprain?
That is a good question. And hopefully we will know a lot more about this in the future. I think we are now thinking more and more towards the medial side again, after it has been kind of forgotten for a few years. But I think it has something to say, because the syndesmotic injuries are now proposed to be a kind of a rotational injury mechanism. De Hooch and his co-workers presented this as something you can compare with the ACL injuries. And in ACL injuries, you have a lot of concomitant injuries. You have now you do the lateral tenodesis on the lateral side, and you have a lot of these things that are mixed up together in one injury mechanism. And we think the same goes for the syndesmotic injuries. It's kind of a rotational pivoting injury mechanism. And I think the medial side also has something to say. And I scoped one patient yesterday, actually, where he had complete rupture of the ITFL, and he had all the anterior part of the deltoid ligament lifted off the medial malleolus. And if this heal in a kind of a more loose sense of way, you will have some more external rotation instability. So I think the medial side for sure is important.
Thank you, Mette. And Mette, you mentioned about the weight-bearing CT scan, right? Now, can we just take a weight-bearing X-ray in an acute stage to pick a syndesmotic injury?
I think if you have a grade 3 injury where all the ligaments are injured, you might get a somewhat clue of increased tibiofibular space, but it's difficult. I often ask for it because it's easier to do compared to a CT scan, for example, and CT scan weight bearing is difficult. So if you do a non-weight bearing CT scan, it's difficult to see the subtle instability. So we don't have the really good, easy examination for that yet, I'm afraid. But in the real high grade of injury, you probably can see the diastasis.
Thank you, Mette. Mette, just one last question before we wind up the session. Mette, you have done a lot of studies looking at screws versus a suture loop or a suspensory fixation, right? So are there any specific complications for the suspensory fixation, like a late breakage of the device?
For the suture button, you mean, or if there are specific complications? In the first study, we used the first generation tightrope, which has where we made knots on the lateral side, and the knot was actually irritating the patient. So we had to remove a lot of the implants because of the knot. Now it's knotless. The implants are knotless, so this is not so big of an issue. It's important on the medial side to be sure that you don't have any soft tissue impingement, because that can be painful for the patient and require removal later. We have in the tricortical study, we had one fracture in an osteoporotic lady. She was not so compliant. She walked from day one, and she had a tibial fracture. And I have also seen outside of the studies several fractures in the suture button tunnel, especially if you also have a posterior malleolar fracture where you have screws and perhaps the tightrope canal conflicting. So it will be a lot of stress in one area, and we have seen some fracture in that kind of patient. So I am kind of reluctant with the suture button in fracture patient in elderly osteoporotic bone. But I know there are many opinions on this. This is my personal opinion on this.
Thank you, Mette. Mette, I think that's all the questions that we have for this session. Thank you for this spectacular presentation, and I'm sure this is going to benefit a lot of people. Thank you.
Thank you.